Hi, I'm Dr. Mike McInnes. I'm one of the chief educators at Doctors in Training, and I want to welcome you to this solid anatomy video on the pelvic organs and the reproductive organs. In this video, we're going to discuss the gastrointestinal and genitourinary organs that are found in the pelvis, and then toward the end of the lecture, we'll discuss the reproductive organs. Now, I'll be back a little bit later for a clinical correlation and the end of session quiz, but for right now, I'm going to turn things over to our primary lecturer, Dr. John Phelan.
The pelvis sure doesn't look particularly complex if you open up the abdomen and look through the superior pelvic brim. That's because the peritoneum lining the abdominal cavity is covering the myriad nerves, blood vessels, and viscera that fill the true pelvis. In the male, the peritoneum drapes over the bladder, the superior part of the seminal vesicles abutting the bladder posteriorly, and the rectum. In the female, the peritoneum lies atop the bladder, the uterus, and the rectum. Thus, in the male, there is a single peritoneal pouch that's between the bladder and the rectum called the rectovesical pouch. In the female, there is a vesicouterine pouch between the bladder and the uterus, and a rectouterine pouch between the rectum and the uterus. The most inferior extent of the peritoneum in the male is the rectovesical pouch. The most inferior extent of the peritoneum in the female is the rectouterine pouch, which is also called the pouch of Douglas. Well, it's about time to tear off the peritoneal covering of our basin and dig into the viscera that fills it. Below the peritoneum, two other spaces of note are the retropubic space between the pubic bone and the bladder, and the retrorectal space between the sacrum and the rectum. If you've watched the solid anatomy lecture on the pelvic wall, you're familiar with the autonomic nerve plexuses of the pelvis. But let's review them anyway, since they are responsible for innervation of the pelvic viscera. The superior hypogastric plexus, which is located anterior to the bifurcation of the aorta, is made up of sympathetics from spinal cord levels T10 to L2. It gives off branches to the lower part of the gastrointestinal tract, but it does not send any direct branches to the pelvic viscera. The terminal branches of the superior hypogastric plexus are the right and left hypogastric nerves, which pass through the superior pelvic aperture. The inferior hypogastric plexus, which is anterior to the sacrum, contains sympathetic and parasympathetic nerve fibers. The sympathetics are from the left and right hypogastric nerves from the superior hypogastric plexus and from the sacral extensions of the sympathetic trunks. The parasympathetics in the inferior hypogastric plexus are the pelvic splanchnic nerves, which originate from spinal cord levels S2, S3, and S4. It can thus be stated that sympathetic and parasympathetic innervation to the pelvic viscera comes from the inferior hypogastric plexus. More specifically, the sympathetic innervation to the pelvic viscera comes from the hypogastric nerves and the sacral sympathetic trunks via the inferior hypogastric plexus, while the parasympathetic innervation comes from the pelvic splanchnics via the inferior hypogastric plexus. While most of the digestive tract is found within the abdomen, it terminates in the pelvis. The rectum begins at the end of the sigmoid colon, or the rectosigmoid junction, which is found at about the level of S3, and it ends at the anorectal junction, at the level of the tip of the coccyx, which is also the level of the pelvic diaphragm. The superior third of the rectum is covered by peritoneum anteriorly and laterally, and is thus intraperitoneal. The middle third is covered anteriorly, making it retroperitoneal, and the distal third of the rectum is entirely below and not in contact with the peritoneum, so it is classified as subperitoneal or infraperitoneal. There are two flexures in the rectum. The superior flexure is found where the rectum is conforming to the kyphotic curve of the sacrum. The other is at the anorectal junction, where the puborectalis muscle forms a sling around the rectum and pulls it anteriorly. The terminal part of the rectum, which is called the ampulla, is dilated and rests on the pelvic diaphragm. The rectum is continuous with the anal canal in the perineum. Blood is supplied to the rectum by the superior rectal artery from the inferior mesenteric artery, the middle rectal artery from the internal iliac system, and the inferior rectal artery from the internal pudendal artery. The three rectal arteries anastomose with each other. Three muscles surrounding the rectum and the anal canal are involved in the process of defecation. These are the puborectalis, the external anal sphincter, and the internal anal sphincter. As was detailed in the solid anatomy lecture on the pelvic wall, the left and right puborectalis muscles originate on the posterior surface of the body of the pubis and pass along the lateral sides of the rectum, uniting in the midline posterior to the rectum to form a sling around it. The puborectalis is part of the levator ani and is thus innervated by branches of the pudendal nerve and sacral ventral rami. The external and internal anal sphincters surround the anal canal in the perineum. The external anal sphincter is voluntary and is innervated by the inferior rectal nerve, which is a branch of the pudendal nerve. The internal anal sphincter, which is located at the same level as the external anal sphincter, but is deep to it, is involuntary. To prevent anal leakage at rest, constant sympathetic innervation of the internal anal sphincter is necessary. When the ampulla of the rectum is full, the muscle fibers in its walls are stretched, which triggers a parasympathetic response that causes inhibition of the sympathetics, which results in relaxation of the internal anal sphincter. At this point, defecation may be resisted by voluntary contraction of the puborectalis muscle and the external anal sphincter. When the puborectalis muscle contracts, it pulls the distal rectum anteriorly and decreases the angle of its inferior flexure, which prevents defecation in the same way that the flow of water through a hose is limited by bending the hose. When the puborectalis relaxes, the angle of the flexure of the distal rectum increases, that is, the rectum straightens out. If the external anal sphincter is then relaxed, defecation will occur. The urinary system includes the kidneys, the ureters, the urinary bladder, and the urethra. The kidney and the proximal portion of the ureters are discussed in the solid anatomy lecture on the posterior abdominal wall and viscera. If you've watched that lecture, you may recall that the ureters travel inferiorly and retroperitoneally along the posterior abdominal wall until they cross the pelvic brim and enter the true pelvis. As the ureter approaches the base of the bladder, it is crossed anteriorly by the uterine artery in the female and by the ductus deferens in the male.
I want to break in here for just a second and identify a few things before Dr. Phelan continues. Now, there are a couple of concepts here that you're going to see again on the ward, so let's highlight a few of these right now. One concept is that the ureters run retroperitoneally from the kidneys down toward the bladder. And the place where the ureters join the bladder is called the ureterovesicular junction, or the UVJ. Now, this is a very important landmark because the UVJ is a very common site for renal stones to get stuck, so remember that. Another thing to know is that the ureters pass under the uterine artery in females and under the vas deferens in males. And we talked about that in this solid anatomy video on the pelvic blood supply. Remember, the mnemonic is water under the bridge, and the urine is the water and the bridge is whatever the other structure is. So you can see here the ureter is coursing underneath or posteriorly to the ductus deferens in the male, and then in the female the ureter courses under the uterine artery. And again, this is relevant because the ureters can commonly be injured during pelvic surgery. You certainly don't want to ligate a ureter by accident thinking it's the uterine artery. All right, let's get back to Dr. Phelan.
Parasympathetic innervation causes peristalsis of the walls of the ureters, which propels urine towards the bladder. The superior portion of the ureter receives parasympathetic innervation from the vagus nerve, while the inferior portion receives parasympathetic innervation from the pelvic splanchnics via the inferior hypogastric plexus. The urinary bladder usually lies entirely within the true pelvis when it's empty, but extends beyond the level of the pelvic brim into the abdomen when it fills. It has an apex anteriorly, which is continuous with the median umbilical ligament, and a neck inferiorly, where it narrows as it approaches the urethra. Its superior surface is covered by peritoneum, and its anterior surface is adjacent to the pubic bone and the pubic symphysis. At the base of the bladder in the male is the prostate gland. Adjacent to the base of the bladder in the female and the prostate gland in the male is the levator ani. The smooth muscle that composes the walls of the urinary bladder is called the detrusor muscle. At the base of the inner surface of the bladder is a smooth triangular area called the trigone, whose vertices are the left and right ureteral openings and the internal urethral orifice. The ureters enter the bladder obliquely and form a one-way valve. As the bladder fills, urine pushes against its walls and squeezes the valvular mechanism closed to prevent urine from flowing back into the ureter. Peristaltic contraction of the ureters create urinary pressure on the other side of the opening that force the valvular mechanism to open and allow urine to enter the bladder. Supplying blood to the superior half of the urinary bladder are the superior vesical arteries, which often branch from the umbilical arteries. The inferior half of the bladder is supplied by the inferior vesical arteries, which also supply the prostate and the seminal vesicles. There is no inferior vesical artery in the female. Instead, the vaginal arteries supply the inferior half of the bladder along with the vagina. The male urethra has 3 portions, each named according to the structure that surrounds it. The urethra begins at the internal urethral orifice at the base of the bladder and passes through the adjacent prostate gland, where it is called the prostatic urethra. On the posterior wall of the prostatic urethra is an elevated area called the urethral crest. At the peak of the crest is a rounded area named the seminal colliculus, which has 3 openings. The superior unpaired opening is the prostatic utricle, which is the homologue of the uterus. Inferiorly are the paired openings for the ejaculatory ducts, which will be discussed momentarily. On either side of the crest are the prostatic sinuses. The sinuses are covered by tiny openings for the prostatic ducts that carry the fluid produced by the prostate gland. At the inferior border of the prostate, the urethra passes through the urogenital hiatus of the levator ani and enters the deep perineal pouch, where it is surrounded by the sphincter urethrae muscle. This portion of the urethra is called the membranous urethra. The urethra leaves the deep perineal pouch by passing through the perineal membrane into the bulb of the penis. The urethra is surrounded by corpus spongiosum as it passes through the bulb, shaft, and glands of the penis. So this portion of the urethra is called the spongy urethra. The ducts of the bulbourethral glands in the deep perineal pouch of the male penetrate the perineal membrane and open into the proximal end of the spongy urethra. The urethra terminates at the external urethral orifice at the tip of the glands. There is no sphincter at the glands. The involuntary urethral sphincter surrounds the internal urethral orifice at the base of the bladder, and the voluntary urethral sphincter is the sphincter urethrae muscle in the deep perineal pouch. The female urethra is shorter than that of the male and is not categorized into segments. It begins at the internal urethral orifice at the base of the bladder. Females do not have an internal urethral sphincter, but the muscle fibers of the neck of the bladder behave in the same way as the internal urethral sphincter in the male. The urethra passes through the urogenital hiatus of the levator ani just anterior to the vagina and enters the deep perineal space. Here it is surrounded by the sphincter urethrae and compressed superiorly and laterally by the compressor urethrae and urethrovaginal sphincter. These are voluntary muscles involved in blocking the flow of urine through the urethra in the female. The urethra ends in the external urethral orifice, which is found in the vestibule of the vagina just anterior to the vaginal orifice. The process of micturition involves the urethral sphincters and the smooth muscle in the ureters and the bladder. The organs of the male reproductive system include the testes, the ductus deferens, the seminal vesicles, the ejaculatory ducts, the prostate gland, the bulbourethral glands, the penis, and the urethra. The testes and the proximal portions of the ductus deferentia are discussed in the solid anatomy lecture on the anterior abdominal wall. Lateral to the ampulla of the ductus deferens is the seminal vesicle, which is a gland constructed as a coiled tube. Its secretions contribute to the semen, but it does not store sperm. The duct of the seminal vesicle unites with the ampulla of the ductus deferens to form the ejaculatory duct, which passes through the posterior wall of the prostate gland and travels anteriorly through the gland to open into the prostatic urethra. The ampullae of the ductus deferens, the seminal vesicles, and the ejaculatory ducts are all paired structures. As we noted moments ago in our description of the urethra, the ejaculatory ducts open on the seminal colliculus just inferior to the prostatic utricle. The prostate gland has a fibromuscular component, but is mostly composed of glandular tissue. The base of the gland abuts the bladder, while the apex is found inferiorly, passing through the urogenital hiatus of the levator ani and resting on the fascia of the muscles of the deep perineal pouch, the sphincter urethrae, and the deep transverse perineal muscle. The posterior wall of the prostate gland is adjacent to the rectum, which allows it to be palpated during a digital rectal exam. The prostate gland produces fluid contributing to the semen, which enters the prostatic urethra through multiple ducts that open at the prostatic sinuses. In the deep perineal pouch, lateral to the membranous urethra, are the bulbourethral glands, or Cowper's glands, which are embedded in the sphincter urethrae muscle. Despite their proximity to the membranous urethra, their ducts do not open into this part of the urethra, but rather penetrate the perineal membrane and pass through the bulb of the penis, where they open into the spongy urethra. The artery supplying blood to the inferior half of the bladder, the distal end of the ductus deferens, the seminal vesicles, and the prostate gland is the inferior vesical artery.
All right, welcome back. Now I want to break in here and discuss briefly the innervation of the male sexual response. This is definitely high yield for your board exams. Now this can get a bit dense, but I'm going to break it down for you at the end of our discussion. So parasympathetic innervation to the seminal vesicles, the prostate, and the bulbourethral gland is secretomotor. So parasympathetic innervation, as you may recall, results in an erection. Emission, however, is mediated by the sympathetic innervation. So emission is where the sperm and seminal fluid are pushed into the prostatic urethra, and then ejaculation occurs when the semen is pushed from the prostatic urethra outside the body. So anyway, emission is mediated by the sympathetic nerves. So So sympathetic innervation causes peristalsis of the ductus deferens, the vas deferens, and that propels sperm from the epididymis, where they're stored, into the ejaculatory duct. It also causes the smooth muscle of the prostate gland to contract, which forces the secretions of the gland into the prostatic urethra through the prostatic ducts. And additionally, even though the bulbospongiosus and the ischiocavernosus muscles are striated muscles that can be voluntarily contracted and relaxed, they also receive sympathetic innervation that causes them to involuntarily, rhythmically contract during ejaculation. And it's the rhythmic contractions of the ischiocavernosus muscles that squeeze blood into the shaft of the penis to maintain erection during ejaculation. Meanwhile, involuntary contractions of the bulbospongiosus muscles squeeze the bulb of the penis, and that forces blood into the shaft and the glands of the penis to maintain erection, and it compresses the spongy urethra within the bulb to propel semen through the urethra. So a mnemonic for all this business is point and shoot. So the P in point helps you to remember the parasympathetic for point or erection, and then the S in shoot helps you remember the sympathetic for shoot or emission. And one other mnemonic I'll throw in here for just a second is that the nerve roots that are responsible for erection are S2, S3, and S4. So you can remember S2, S3, and S4 keep the penis off the floor. And on that note, let's get back to Dr. Phelan.
The reproductive organs of the female include the vagina, the uterus and associated structures, and the ovaries. The vagina is a distensible muscular tube that serves as the organ of copulation in the female, the canal for menstrual blood, and the inferior portion of the birth canal. It extends from the uterus to the vestibule of the vagina. Recall that the vestibule of the vagina is between the labia minora. The inferior third of the uterus, which is called the cervix, projects into the superior part of the vagina. The recess around the cervix within the vagina is called the fornix. As the vagina passes through the urogenital hiatus of the levator ani, the pubococcygeus and puborectalis muscles partially surround it and act as vaginal sphincters. As the vagina passes through the deep perineal pouch, the urethrovaginal sphincter muscle also passes lateral to it on either side and acts as a vaginal sphincter. Finally, as the vagina passes through the superficial perineal pouch to open at the vestibule, the bulbospongiosus muscles are found on either side of it and may also be acting as a weak vaginal sphincter. Blood supply to the vagina is by the vaginal artery in the pelvis and the perineal artery in the perineum. The vaginal artery anastomoses with the uterine artery. The inferior fifth of the vagina receives somatic innervation from the perineal nerve and is sensitive to pain, touch, and temperature. Pain fibers to the remaining 80% of the vagina run in the parasympathetics, or pelvic splanchnics, in the inferior hypogastric plexus. This portion of the vagina is sensitive only to stretch. The uterus is usually anteroflexed and resting on the bladder, so the bladder is providing some support for the uterus. The inferior one-third of the uterus is the cervix, which is firmly anchored to the walls of the pelvis by ligaments formed from endopelvic fascia. The endopelvic fascia occupies the spaces between the pelvic viscera and consists mostly of elastic fibers, fibrin, and smooth muscle fibers. It condenses to form two pairs of ligaments that anchor the cervix to the pelvic walls and provide support for the uterus. The uterosacral ligaments run posteriorly from the cervix to the sacrum. The transverse cervical ligament, or cardinal ligament, runs from the cervix to the lateral wall of the pelvis. The uterine vessels run in the transverse cervical ligament. The superior two-thirds of the uterus is the body, which is freely movable. The rounded portion of the body that extends superior to the proximal ends of the uterine tubes is the fundus. The narrow area of the uterus between the body and the cervix is the isthmus. The uterus is a hollow organ with thick muscular walls. It has 3 layers: a thin perimetrium, which is its outer serous coat, an endometrium, which is the mucosal lining that is partially shed during menstruation, and between them a thick myometrium, which is composed of smooth muscle. Extending from the lateral walls of the uterus are, from anterior to posterior, the round ligament of the uterus, the uterine tube, also known as the fallopian tube, and the ovary via the ligament of the ovary. The peritoneum covers the body of the uterus and the structures extending from the body to form a mesentery called the broad ligament. It extends laterally to cover the ovarian vessels, thereby forming the suspensory ligament of the ovary. The portion of the broad ligament covering the uterine tube is the mesosalpinx. Salpinx is the Greek word for trumpet, the instrument that a long-gone Greek anatomist thought the uterine tube resembled. The portion of the broad ligament covering the ovary is the mesovarium. The mesovarium, or mesentery of the ovary, is oriented perpendicularly to the mesosalpinx, or mesentery of the uterine tube. The mesometrium is the portion of the broad ligament that covers the uterus. Extending from the lateral side of the uterus and running anteriorly is the round ligament of the uterus, a fibromuscular remnant of the gubernaculum, which assisted in descent of the ovary in the embryo. It is covered by the broad ligament. The round ligament of the uterus passes through the deep inguinal ring, traverses the inguinal canal, and exits the superficial inguinal ring to enter the labia majora, where it is anchored. The ovary is an endocrine gland where the ova develop. It is located posterior to the distal end of the uterine tube. The ovarian ligament, another remnant of the gubernaculum, connects the ovary to the lateral wall of the uterus. This is not to be confused with the suspensory ligament of the ovary, which suspends it from the lateral wall of the pelvis. Blood is supplied to the ovary by the ovarian artery, which, as you may recall from the solid anatomy lecture on the posterior abdominal wall and viscera, is a branch of the aorta. The distal end of the uterine tube is called the infundibulum because it is shaped like a funnel, and the Latin word for funnel is infundibulum. The infundibulum opens into the peritoneal cavity through the free edge of the mesosalpinx. It has finger-like projections called fimbrae that pulsate and generate a current in the peritoneal fluid that draws the expelled ovum into the uterine tube. From the infundibulum, the ovum passes into the ampulla, which is the longest, widest part of the uterine tube and is the usual site of fertilization of the ovum. The narrowed portion of the uterine tube between the ampulla and the uterus is called the isthmus. The portion of the uterine tube that runs through the wall of the uterus is the intramural part. Blood supply to the uterus is from the uterine artery, which is a branch of the internal iliac arterial system. The uterine artery anastomoses with the ovarian artery, which branches from the aorta, and with the vaginal artery, another internal iliac branch. Furthermore, the vaginal artery anastomoses with the inferiorly located perineal branches of the internal pudendal artery. Branches of the ovarian artery also supply the uterine tubes.
Now it's time for the end of session quiz. So pause the video and answer the questions in the end of session quiz in your study guide, and then we'll go through those answers together. All right, let's get started. First question, what is found in the seminal colliculus, and what are the roles of these structures? So there's the prostatic utricle, which has no function at all. It's just the remnant of the old female duct system. You also find the openings of the ejaculatory ducts, which are the site of emission from the vas deferens and the seminal vesicles. Next, where's the pouch of Douglas located? Well, this is the most inferior extent of the peritoneum in the female. It's also called the rectouterine pouch, so it's found between the rectum and the uterus. Next, which duct is formed as the vas deferens joins the duct of the seminal vesicle? It's called the ejaculatory duct. Next, what's the difference between emission and ejaculation? Again, emission is moving sperm and seminal fluid to the prostatic urethra, and then ejaculation is moving the semen from the prostatic urethra through the penis and outside the body. Next, what nerve roots are responsible for erection and sensation of the penis? Remember we said S2, S3, and S4 keep the penis off the floor. All right, the last part. We've got some images for you to label in your mock practical. So label all those images, and then you'll be finished.
So, we meet again, 00.
You'll never get away with this gold.
Oh, really? Well, I think my new pets may beg to differ.
You are a sick, twisted man.
It doesn't have to come to that, 00. All you have to do is answer me one simple question.
Never. You'll never get information out of me.
Never say never, 00. Prepare the bunnies!
No, okay. I'll tell you anything you want. Just have mercy, please.
How does autonomic stimulation affect the normal male sexual function?
There's nothing about my sexual function that's normal.
Release the bunnies!
Okay, I'll tell you. Parasympathetic stimulation causes erection, and sympathetic stimulation causes ejaculation. Oh no! How could you not know that? It's as easy as point and shoot.